We're taking a piece of your specimen, your biopsy of your colorectal cancer, as we're looking to see if there's a specific gene or molecular alteration that would be detected in your colorectal cancer cells. If there is, do we have a therapeutic option that has been known to target that specific molecular alteration, essentially sparing your normal cells? My name is Jun Gong, and I'm a practicing GI medical oncologist here at Cedars-Sinai Medical Center, specializing in gastrointestinal malignancies, where we focus on the organs of the digestive tract, the lining of the esophagus, all the way to the stomach, small intestines, large intestines, down to the rectum and anus. In the past, we didn't have much in terms of treatment options. For advanced stages of disease, all we had was what we call old school intravenous chemotherapy, where patients would experience a lot of side effects. In the current age, we've seen some substantial improvements, specifically in the field of targeted therapy, where now, in combination with chemotherapy, and sometimes just by itself, we have these newer treatments that are available that are not only more effective, but they also are very tolerable and can really change the outcomes of patients in this stage. Now, how do we target our drugs, our chemotherapies, our medicines to the tumor? What we look for is a specific type of mutation. We're looking at alterations in the genes and the proteins that the tumors uniquely express. You need to look for these alterations in your tumor. Where in breast cancer, if patients had HER2 amplified tumors, you use a HER2 targeted therapy. And believe it or not, we now begun to use that in colorectal cancer as well. Even if your colorectal cancer does not have a targetable alteration, you can still use biologic medicines such as bevacizumab combined with chemotherapy in the first line as an effective therapy. Then you have more targetable alterations that if you can identify, you can really tailor your treatment approach with or without chemotherapy in advanced colorectal cancer setting. Here at Cedars-Sinai, we have multiple clinical trials where we're actually looking at novel agents that specifically target specific molecular alterations in our colorectal cancer, whether it be HER2, microsatellite stability, or MSS. These are a couple of examples of how clinical trials can be sought for at every setting of treatment and where we have options to better and improve the current standards of care. This is the general overview of the algorithm of how I approach advanced unresectable or metastatic colorectal cancer treatment, walking you through the molecular profile, what to look for, first line, second line, left-sided, right-sided, and based on molecular phenotypes, really help guide the clinician in the current landscape of treatment of metastatic colorectal cancer. The patient who presents to the clinic with advanced or metastatic colorectal cancer needs to have next-generation sequencing or molecular profiling of their tumor specimen because the treatment landscape currently is very heavily molecular driven. Based on these results, the first thing that I look for is their microsatellite instability status. Are they MSI high or are they MSS? If they are MSI high, then we look for immunotherapy, specifically pembrolizumab, based on its recent FDA approval from the Keynote 177 trial. If they are MSS, then we go down a different algorithm. Here, based on the sidedness of the tumor, whether they are right-sided or left-sided, can also impact treatment choices. On this part of the algorithm, the basic foundation remains a cytotoxic chemotherapy backbone, usually either an oxaliplatin-based combination or an irinotecan-based combination. For right-sided tumors, we tend to use these combination chemotherapies plus a biologic such as Avastin. If they are more of a younger, fit performance status, you can even consider a triplet plus or minus Avastin, which is FOLFOXIRI, for example. If they are left-sided, based on the molecular status, specifically if they are RAS wild type or BRAF wild type, then you have the option of the cytotoxic chemotherapy backbones plus an anti-EGFR agent for left-sided tumors. However, one could also rationalize using Avastin with the cytotoxic chemotherapy backbone as well. Beyond the first line therapy, again, if the patient is MSI high or microsatellite instability high status, you can use these refractory immunotherapy FDA labels for which there have been approvals for nivo-ipi, nivolumab, and even pembrolizumab, as well as dostarlimab, which was recently approved by the FDA as well in patients who are refractory to standard agents. Here, the molecular subtype becomes more helpful as well. For example, if you are RAS or BRAF wild type, again, you have the anti-EGFR plus chemo option available in the second and beyond refractory settings. If you have a BRAF mutated patient, here there's been an FDA approval for the BRAF inhibitor encorafenib plus cetuximab in those who are BRAF mutated refractory to first-line chemotherapy in the BRAF mutated population. In those with HER2 amplified status, this is another molecular target that we commonly look for in colorectal cancer, predominantly on the left side, but if they are HER2 amplified, then based on phase 2 and ongoing clinical trial data, combination anti-HER2 or Herceptin plus lapatinib, for example, is a recognized option. There is also the next generation anti-HER2 targeted agent, trastuzumab deruxtecan, which is available for the HER2 targeted population in advanced colorectal cancer. Beyond the second line, you then look for standard of care options such as regorafenib and TAS-102 that have been approved. You have more rarer molecular subtypes that we should all be aware of, such as NTRK fusions, which render patients available for NTRK inhibitors that are FDA approved as well. And in general, in this territory, as well as those in the first line and second line settings, you always want to look for a clinical trial because this is a high unmet need population where desperate advances in systemic therapies are needed. So we always, and I advise strongly to always look for a clinical trial in the first, second, and third line setting. And lastly, among some other rarer targets, KRAS G12C now has an FDA approval for a KRAS G12C inhibitor in colorectal cancer.